Greeting from the Directive Board of the Latin American Diabetic Foot Society, Alapit, and Ariel asked me to talk about the update on diagnosis and treatment of ulceration, deformation, and clinical aspect, and factors related to the non-healing of neuropathic ulcers. So these are included in our Latin American experience in treating that diabetic foot attack. There's no conflict of interest in this talk. And it's important, I found this message on the social media where I saw this statement about the 85% of all amputations are caused by a foot ulcers. But that is not completely true. The diabetic foot are not simple ulcers. So it's a paradigm that will be considered, because the right statement is that 85% of all amputations are caused by a lower extremity ischemia. It's important to identify what is the part of the contribution of each variable that San Elian Sius included in his published report since 2010. The major amputations correlate to the ischemia according to the three severity grades of San Elian, mainly San Elian grade 2 and 3. So you can see in this slide the contribution of neuropathy to the major amputation secondary to diabetic foot attack, where ischemia is the main variable. The number of affected zones and of course neuropathy is contributing as well. Relate to mortality, the contribution of neuropathy is present here as well in an important way in this multivariate analysis. So we need to change the paradigm from ulcer to diabetic foot attack that we are confronting in all the countries in Latin America and maybe worldwide. We are receiving excellent paper published where we received hard data, but are small neuropathic ulcers. And we are confronting in our real world severe and devastating diabetic foot attack, not a small neuropathic ulcer. So we consider that neuropathy is the main cause of diabetic foot ulcer, but that lower extremity ischemia is the main cause of amputation. The learning objective is to understand the stage of the history of the foot attack for prevention, to understand the diabetic foot attack, and to review the relevance to score a detailed system for initial assessment and follow up for healing progress. First, to understand the state of the history of foot attack for prevention. The stage of the natural story of diabetic foot attack are three stages: stage 1, 2, and 3, previous and post-diabetic foot attack. The stage 1, there is no history of foot attack, a very low risk for wound, amputation, and death. The stage 2 is diabetic foot attack with an imminent threat to patient life and legs loss. And the stage 3, the post-diabetic foot attack with a very, very high risk to develop wound, amputation, and death. So the second learning objective is to understand the diabetic foot attack. The diabetic foot attack is a complex syndrome with one or more wounds with difference in etiology and severity, tissue destruction, amputation, and or death. The natural history of the foot attack is from foot at risk, may progress to chronic attack or progress to a foot attack, acute foot attack. And chronic attack maybe could evolve or progress to acute foot attack. The foot at risk present foot deformities. There is no history of wound or amputation, maybe mild or maybe moderate neuropathy or ischemia grade with the risk of diabetic foot attack and a very low risk of light or lower extremity amputation and treatment. The chronic foot attack is present a history of improvement and worsening. usually are small wounds at plantar ulcer location with a very mild severity in ambulatory patients. The acute diabetic foot attack is an emergency with a high risk of major amputation and death with absence of clinical data. It's a devastating presentation with acutely inflamed foot, with rapidly progressive skin and tissue necrosis, with significant systemic symptoms. May progress to good evolution, to remission, not cure, or finally progress to an adverse outcome with lower extremity amputation or death. The stage 2 is the acute foot attack, according to the Sangelian, present severity difference by wound location, aggravating factors, tissue destruction, wound location by zone, foot aspects, aggravating factors, skin infection, edema, neuropathy. Wound tissue destruction include area, depth, and wound healing phase. The 10 factors of the Sangelian system correspond with the aggravating factors that determine the type of the foot attack. Correlate perfectly. The report of Michael Edmonds and colleagues since a couple of years ago mentioned 3 types of acute attack: infection, secondary to neuropathy or Charcot, or ischemia. But here in Sangelian, according to our system, we added the foot attack by edema and the mixed foot attack. The main example of the mixed foot attack is the kidney attack that includes ischemia, edema, and infection. So the diabetic foot attack by secondary to neuropatia is the acute Charcot that must be present. Wound without wound is not being included in our Sangelian system. Present a significant inflamed foot with foot compartment syndrome. The third learning objective is to review the relevance to score a detailed system for initial assessment and follow-up for healing progress. The Sangelian system for prevention is included as an important part of the IDF clinical practice recommendation of the diabetic foot since 2017. The effort was achieved by many colleges around the world with effort of 2 years to obtain a consensus that was published and presented during the IDF World Congress. This is the IDF printed version of our system, the CU checklist to score a graded diabetic foot attack. And we are announced here the diagnosis of neuropathy severity as part of the 10 wound factors. So neuropathy is mild according to the result of the diminution of protective sensation with the tuning fork or the Simmons-Weinstein monofilament fiber tip or Ipswich test. The moderate enhanced here the absence of this protective sensation, and the severe degree is the Charcot foot. Finally, the sum score are graded in 3 prognostic grades. This is the format for data, score and grading, the checklist of the 10 severity wound factors, the severity grade, and a follow-up chart of the progress or evolution of the wound healing. It's not time consuming, less than 3 minutes to score. It's quickly and very easy after the history chart was made and performed as required. So in this way, we can, the follow-up provide us the whole movie and not only a picture in some moment. The internal and external validation of this system, it's widely performed around the world with hard data. Every day we are receiving the published paper of many of our colleagues around the world that are using the grade of the severity grade. Here we can see the survival probability for the 3 grades and the delay of wound healing, and the 70% of lower extremity amputation grade 3, 30% of lower extremity amputation in 2, and less than 5% in grade 1. So the SEER is a comprehensive system to provide a tool for diagnosis, prognosis, treatment, follow-up, prevention, teamwork, and a very good learning tool. The global impact is, as I mentioned before, in many published papers around the world. And the last 2 papers published is this from Romania that talk about the factors influencing length of hospitalization in patients with diabetic foot ulcer. That the main tool that they assessed their result was made with our San Elian Latin American system. This is the last one that we published, that you can find all the history, the review of all the Latin American system and success and use in Latin America mainly. So finally, we have a very brief an example of the mixed foot attack with acute devastating onset with bilateral edema, skin and tissue necrosis, and acutely inflamed foot that was submitted to surgical debridement on roof of infectious tract. And wound healing progress was observed here with negative therapy pressure and surgical measurement until the remission of the foot attack was obtained. So the San Elian American system is important because the diabetic foot is a biological system involving the combination of independent elements forming a collective entity, interacting and affecting between them through time. So the SEERs provide a unique, useful tool to assess and follow up the diabetic foot as a complex system that presents change through the time. So we have a 3D structure in the initial detailed assessment. There's a severity semaphore for every variable assessed, and the model of 4D that start to work once the first assessment, the second assessment was made. So time is the part of the 4D, as you can see here in English language, the progression to severity. In conclusion, the diabetic foot attack is a severe and devastating problem that increases lower extremity amputation and mortality. The San Elian system provides a validated tool for initial assessment for neuropathic ulcer, preventing its worsening to a devastating diabetic foot attack. The SEERs and our association provide a platform for prevention of diabetic foot attack by early detection of neuropathic ulcers and to reduce amputation and mortality. Thank you.